अस्सलाम वालेकुम डियर स्टूडेंट्स। इन टुडे लेक्चर एंड टुडे सेशन हम बात करेंगे एक और टॉपिक इन द इंटीरियर शोल्डर इंस्टेबिलिटी। इससे पहले जो लेक्चर्स हमने लिया था उसमें हमने यूनिडायरेक्शनल इंस्टेबिलिटी के बारे में बात की थी। हमने डिटेल से डिस्कस किया था कि व्हाट आर द डिफरेंट क्लासिफिकेशन ऑफ द दैट शोल्डर इंस्टेबिलिटी, और उसकी डिटेल हमने डिस्कस की थी। इस सेशन में हम बात करेंगे मल्टी डायरेक्शनल इंस्टेबिलिटी की। लेकिन उससे पहले थोड़ा हम इंट्रोडक्शन देंगे अबाउट द शोल्डर इंस्टेबिलिटी की। Glenohumeral joint, which is a multi-axial spiratal joint, is one of the largest and most complex joints in the body. This joint has the greatest range of movement of any joint, but this leaves it inherently unstable and with the highest chance of dislocation of all the body joints. So higher the range of movement, higher the chance of dislocation. Only 25% of the human head makes contact with the glenoid force at any time, and that is one of the reasons why there is highest incidence of the dislocation of the shoulder as compared to the other joints of the body. Now, what this shoulder instability mean? And this shoulder instability, that simple, it is used to the inability to maintain the humeral head in the glenoid fossa, or somehow we can say that if the humeral head is not in its own position, which is the normal position, if it is somehow subluxed, it have changed its position, it will be called as instability. This shoulder instability may be both the dislocation and subluxation. If it have completely left its glenoid fossa, it will be termed as dislocation. And if it have left partially the glenoid fossa, mean still it's some of its glenoid fossa have some contact with that humeral head. Partially it is outside that glenoid fossa and partially it is inside the fossa, so it may be termed as the subluxation. Multi-directional instability. So there are many definitions in the literature about the multi-directional instability, and unlike the unidirectional where the concepts are very clear, here multi-directional instability, that still there are a number of description and elaboration on this topic. Neer and Foster initially described this multiple directional instability as interior and posterior instability when they are situated with involuntary and field subluxation or dislocation. Similarly, other authors have defined that multi-directional instability, MDI, as instability in at least 2 to 3 directions. MDI can be defined as symptomatic instability in 2 or more directions. So number of definitions they are present in the literature. If we summarize all this definition, multi-directional instability mean when simultaneously there is dislocation of the shoulder joint in interior direction and as well as in the posterior direction. So when 2 or more than 2 direction instabilities they are present at the same time, it will be termed as the multi-directional instability. सेम प्रिंसिपल्स अप्लाई होते हैं एमडीआई के लिए, जैसे प्रीवियस लेक्चर्स में हमने यूडीआई के लिए यूज की थी, जो यूनिट डायरेक्शनल स्टेबिलिटी के लिए हमने यूज की थी। वहां पे हमने ये जो डिस्कशन किया था कि अगर कैप्सुलेबल इंजरीज जो हैं ये मौजूद होते हैं तो मोस्टली जो है वहां पर हाइपरलेक्सिटी जो है की चांसेस नहीं हुई, यानी इफ द जॉइंट इज विद हाइपरलेक्सिटी सो देयर इज लेस चांस ऑफ द कैप्सुलेबल इंजरीज, एंड इफ कैप्सुलेबल इंजरीज आर प्रेजेंट so it means there will be the person will have it's really less chances that the person will be present with the hyperlaxity. MDI patient with soft tissue hyperlaxity will often present with instability in 2 or more directions and display a sign of generalized hyperlaxity on the physical exam. Patients more commonly report relatively frequent recurrent low energy subluxation events. Generalized joint laxity is characterized by increased length and elasticity of normal joint restraints, resulting in a greater degree of oscillation of the articular surfaces. Now, what we mean by the joint restraints, यहाँ से मुराद कैप्सूल भी है थोड़ा कैप्सूल थोड़ा सा लूज हो जाता है। आम हालत में अगर जितना टाइट होता है उसकी टाइटनेस थोड़ी सी उसमें रिलैक्सेशन आ जाती है, कैप्सूल लूज हो जाता है, जिसकी वजह से ह्यूमरल हेड जो है या जॉइंट जो है नॉर्मल रेंज से ज्यादा ट्रांसलेशन उसमें पॉसिबल होती है। इसके अलावा इसकी सराउंडिंग जो लिगामेंट्स होती हैं, जो इसकी मेन स्टैटिक स्टेबलाइजर्स होते हैं किसी भी जॉइंट का, तो उस लिगामेंट्स में भी जो है न सिर्फ उनकी इलास्टिसिटी इंक्रीज होती है बल्कि उनकी लेंथ जो है उसमें भी जो है इंक्रीज आती है। और ये दोनों increase in the length as well as increase the elasticity of these two structures, the capsule and ligaments, will lead to a greater translation inside the joint, और जिसको हम कहते हैं the joint laxity. This hyperlaxity can be congenital, can be acquired. If it is congenital, so it may be caused by a number of different connective tissue disorders, such as the Ehlers-Danlos syndrome or the Marfan syndrome, osteogenesis imperfecta, or it may be because of the benign hypermobility syndrome. In the Ehlers-Danlos syndrome, usually the skin is very loose and it is quite stretchable. Unlike the normal people, it can be stretched up to 6 inches and more than that. Specifically, that skin of the neck and surrounding that shoulder, uh, that is too much stretchable as compared to the other people. In the osteogenesis imperfecta, the density of the bone is much reduced. As we can see here in this images, this is the comparison of the healthy bone density and the osteogenesis imperfecta. There is the density of the internal bone has much reduced to a high extent. In the Marfan syndrome, there are a number of other systemic features, and the most important one that how we will can diagnose that the person has with Marfan's, उनकी जो अगर वो दोनों हाथ जो है इस तरह ओपन रखी, यानी एबडक्शन में लेके 90 एबडक्शन में राइट एंड लेफ्ट अपर लिम्ब जो है एबडक्शन में रखी, तो उसकी जो ये जो हॉरिजॉन्टल लेंथ होगी ये उसके टोटल हाइट से ज्यादा होगी। नॉर्मली एक आम बंदा विदाउट सच मार्फन सिंड्रोम अगर वो दोनों हाथ जो है सर ओपन रखे स्पेन करे, तो स्पेनिंग ऑफ बोथ हैंड्स फ्रॉम राइट middle finger to the left middle finger tip, this horizontal distance will be less than the total vertical height. But in this condition, Marfan syndrome, the distance of the arm spanning will be more than the height of that person. Other systemic features which may be present in the Marfan syndrome, uh, they can be mitral prolapse, aortic dissection, regurgitation of the aortic of fingers long, arm spanning, which we discussed previously, nasal wise, and sternal excavation. All these can be just memorizable through this Marfan's mnemonic, that MARFANS. These will just show the systemic features. Hyperlaxity must be distinguished from the instability. Hyperlaxity doesn't mean that the joint will be subluxed or dislocated, while instability, that is a clear term that the joints will be either dislocated or the joint will be subluxed. Shoulder laxity is the physiological presence of asymptomatic translation of the shoulder joint. It means during the hyperlaxity, there will be only increased translation of that. Suppose if we talk about the glenohumeral joint, so there will be more interior and posterior translation of the humeral head inside the glenoid fossa without any dislocation or subluxation. So it doesn't mean that a person with hyperlaxity will be present and must present with the instability. So shoulder instability, on the other hand, it is a pathological condition which is characterized by the presence of symptoms in conjunction with the abnormal laxity, which is indicative of deficient both static and dynamic glenohumeral joint stabilizer. Static stabilizers that mean the capsule, the ligaments, while dynamic glenohumeral stabilizers, that is all the muscles surrounding the glenohumeral joint, specifically the rotator cuff muscles. Cameron et al., they applied the Boyton criteria to confirm the association between the hyperlaxity and the shoulder instability. The beating scale that is made of 5 items that comprises 5 items, and these 5 items are passive dorsiflexion of the f- finger beyond 90 degree, which we also call as the pinky, and the passive dorsiflexion of the fifth finger, which means pinky beyond 90 degree, passive thumbs opposition to the forearm, active elbow hyperextension beyond 10 degree, active knee hyperextension beyond 10 degree, and forward flexion of the trunk with knees fully extended so that the palms of the hands rest flat on the floor. These are those 5 points. This is that dorsiflexion of the pinky. The second one, the third one, which is if it is more than 10 degree, then if this is the hyperextension of the knee, and this is the fifth one when the person with straight knees and can touch the floor with the palms of the hand. So if it is present, this condition is present, so it is scored on the both sides, so it means it will have 2 scores. Each item except for the trunk flexion, this last one, is scored bilaterally and the total score ranges from 0 to 9. So if we look at this diagram, that is 1 score for the right hand and 1 for the left. Similarly, 1 for the right thumb and 1 for the left. Right and left elbow 2 points. Right knee joints 2 points. So that will make total 8 score, while this trunk flexion will carry 1 mark. If the condition is this condition is present, it will receive 1 score, and if it is present, it will receive 0 score. So it means the minimum score is 0 and the maximum score is 9. The authors showed that patients with a Bruton score of 2 or greater were nearly 2.5 times more likely to have experienced an episode of shoulder instability than patients with lower score. It means there was a positive association between the Bruton score and the chances of the instability. It means higher the score and the British score, higher the risk for the shoulder instability will be. Now, what are the long-term implications of this MDI and this multidirectional instability? So, first of all, this multidirectional instability that will lead to the changes and alteration in the biomechanism of that complete shoulder girdle. Now, what are those changes which will be just because of that MDI in the shoulder girdle? So, among them, the glenoid bones loss decreases the available articular arc and generate glenoid humeral mismatch. So, this mismatch, glenoid humeral mismatch, is the first change in the abnormal change in the biomechanics, eventually after the multidirectional instability. The former generates a smaller articular arc length and decreased surface area by which the glenoid cavity can resist transmitted axial forces from the proximal humerus, thus failing to address that glenoid bone loss even at the time of surgical fixation will result in significant shear forces imparted to a repaired capsulabral interface. Other implications, which will be just because of that MDI, this is the scapular dyskinesia, and this dyskinesia, according to research, it is reportedly to be present in almost 80% of all the instability cases. The biomechanical abnormal scapular posturing leading to pathologic anterior tensile loads and shear forces that include there will be excessive anterior tilting, internal rotation, and protraction of the scapula. And these changes, excessive changes in these movements will be the biomechanical implication of the MDI. In addition to the scapular kinesia predisposing to the anterior shoulder instability also include decreased upward rotation of the scapula during the scapulothoracic movements. The end result of altered scapular position yields excessive tensile load and shear forces experienced by the anterior band of the inferior glenohumeral ligament. It means there will be more demand and more pressure and force on the inferior band of the IGHL. It means there is high chances for the rupture of this ligament when there is excessive tensile load and shear forces. And that is one of the reasons why during this multidirectional instability and specifically the interior instability, just because of that increase in the tensile and shear forces, um, there is in most of the cases there is rupture of the in interior band of the IGHL, the inferior glenohumeral ligament. Another implication is the recurrent instability. Recurrent instability can be present following non-operative and operative management. In a study, authors have reported that almost 90% of the contact athletes and up to two-thirds of the non-contact athletes with significant glenoid bone loss ultimately fail surgical stabilization secondary to associated brain cartilage or abnormal glenoid morphology, affecting overall glenohumeral biomechanics. The third implication, the long-term implication of this MDI, that shoulder instability, is the dislocation arthropathy. There is a specific term which is being termed and given to the condition when there is some arthritic changes after that shoulder instability. In 1982, Neer was the person who first described a subset of patients with a history of the shoulder instability events that developed glenohumeral arthritis at long-term follow-up. The condition was officially termed as dislocation arthropathy, and then in the 1 year later, in 1983, the Samuelson and Pretus reported that these arthritic changes could follow even if there is a single dislocation event. Dislocation arthropathy describes the degenerative changes of the shoulder joint. In a study conducted by the Hovelius and Rame, conducted a prospective study of 257 primary anterior shoulder dislocation in 255 patients. A 25-year follow-up, they revealed that 27% had mild glenohumeral arthritis, and as well as 34% had moderate to severe arthrosis, that degenerative changes. These findings indicate that that is not a very rare case. That arthropathy, their arthritic changes after instability, is not a rare phenomenon. This is not a rare happening. Almost it is near to the one-third of all cases, 27% and 34 cases. Another point which is revealing from their findings is that most of the patients, they are present with the moderate to severe arthrosis, and less were present with the mild arthritis, glenohumeral arthritis. The next topic which we will discuss is the histopathology of the shoulder instability. Various histologic studies have investigated the proprioceptive characteristic of the soft tissue elements of the glenohumeral joint. That actually what happened to that soft tissues after the instability. If there is dislocation, so what will be the changes that will be occurred in the microscopic changes in the capsule, in the ligaments, in the other structures after that instability, after that dislocation. So the Ruffini corpuscles and the Ficini corpuscle are distributed throughout the capsular ligamentous complex. These are the mechanoreceptors, type 1 and type 2, and they are present throughout the capsular ligaments complex. They are present in the capsule, they are present in all ligaments. The glenohumeral joint capsule and labrum, they are mechanoreceptor containing tissues, and damage to articular mechanoreceptor can result in the proprioceptive deficit that may lead to the recurrent instability. The afferent endings, they are susceptible to injury during the instability events. They are resulting in delayed delivery of the proprioceptive signaling, and this subsequently then results in delayed signal of transmission. Not only that delay will be in the signal transmission, but it will also eventually lead towards that delayed muscle responses or some dysfunctional muscle responses. In contrast to the microscopic findings among different grades of shoulder instability, a study detected no correlation between the clinical items as well as histologic pyramid. It means that doesn't matter what is the age of the patient, what was the number of dislocation, what was the history of dislocation. It was 3 months, 6 months, or 1 year of that initial dislocation. There was no such correlation. There was no relationship between all these demographic and all these clinical items and as well as the histopathologic parameters. It means that the pathological changes in the microscopic pathological changes in the tissues, they were similar in all age patient of all ages. They were present in patients regardless that what was the number of dislocation, and they were present in both the acute and chronic cases. These clinical items seem to be independent from the tissue status of the static stabilizer of the shoulder. Independent mean that they are not depending on each other. There was uh, not a significant correlation was present between them. Now, if there is a patient with the instability, so what will be the symptom? What will be the clinical presentation of such patient? So first of all, we will discuss the clinical presentation of anterior instability, and after that, we will discuss the posterior instability. In anterior instability, the person will be present with the dead arm syndrome and the rotator cuff weakness, increased joint accessory motion. There may be presence of Bankart lesion, the Hegel and Giggle, which is actually that humeral avulsion of that glenohumeral ligament and the glenite avulsion of that glenohumeral ligament. L-sac defect will be present, and that is very common in the anterior dislocation. Now, what does this dead arm syndrome mean? Usually ये डेड आर्म सिंड्रोम जो होता है ये उन लोगों में ज्यादा होता है जो थ्रोइंग या ऐसी होती जो ओवरहेड एक्टिविटीज में इन्वॉल्व होते हैं, लाइक वॉलीबॉल हो गई, लाइक बैडमिंटन हो गई, पिचिंग हो गई, या कोई भी क्रिकेट हो गई, ऐसी गेम जिस एक्टिविटीज जिसमें ओवरहेड एक्टिविटीज होती हैं. जरूरी नहीं कि वो स्पोर्ट्स ही हो, डेली लाइफ एक्टिविटीज में भी जो ओवरहेड एक्टिविटीज होते हैं उसमें ये बंदा जो है स्पेसिफिकली विद शोल्डर इंस्टेबिलिटी, उसमें उतनी वो ताकत नहीं होगी, उसमें उतनी जो है वो पावर नहीं होगी कि वो ओवरहेड एक्टिविटीज उस इंटेंसिटी से करे जो उससे पहले ये कर सकता था. सो दे ये बहुत वीकनेस उसमें आ जाती है. सो दिस डेड आर्म सिंड्रोम दैट इंडिकेट्स दैट द पैथोलॉजिक इंटीरियर इंस्टेबिलिटी. It occurs when the arm is in the abducted and externally rotated position. That is very important to remember that in the dead arm syndrome, what is the position of the shoulder? The arm की position क्या होती है? So that is abducted and externally rotated position. The patient complains of sharp interior shoulder pain and tingling in the hand and drops the arm suddenly. And that is why it is known as the dead arm syndrome, that there is dropping of the arm. Suddenly the person can't hold that arm. This syndrome is often seen in varied sports such as volleyball, tennis, swimming, and water polo. So the important point is that what will be the arm position during the dead arm syndrome and why it is known as the dead arm syndrome and in which sports the dead arm syndrome is commonly present. Another clinical presentation in the anterior instability is the weakness of the rotator cuff muscles, particularly in the external rotation, and empty can abduction is common in athletes with anterior instability. There will be increased joint accessory motion, specifically in the anterior direction. Bankart lesion, because we have discussed earlier in the unidirectional instability, the anterior dislocation doesn't mean exactly in the anterior dislocation, but the dislocation is mostly in the anterior inferior direction. So if we look at that clock, this position of that exiting the glenate fossa is between the 3 and 6 o'clock position. And when it is going to exit, so there is abutment of the posterior lateral and posterior lateral superior humeral head with the that rim as well as that labrum between the 3 o'clock position and the 6 o'clock position. So injury to the labrum between the 3 o'clock and 6 o'clock position is known as the Bing cartilage. They are very common conditions. They are very common consequence of the traumatic anterior shoulder instability. Hegel and Giggle, they are also present. The health sac defect, that is again a very common condition with the traumatic instability, and it has been observed in a study that 80% of the patients with initial anterior dislocation, they were present with the health sac defect. And in 100% of patients with recurrent anterior instability, it means the chances of health sac defect increases as there is the number of recurrent anterior instability increases. So higher the number of episodes of anterior instability, higher the depth, higher the chances of the health sac lesion will be. Health sac defect is also known as the health sac lesion. So now what are the symptoms of the recurrent anterior instability? Obviously, there will be glenohumeral joint pain, specifically at the abduction and external rotation position. Shoulder stiffness will be there, and there will be difficulty warming up the activity. There will be weakness of the rotator cuff, sensation of the popping, grinding, and catching deep in the shoulder joint, pain when reaching the backward or above the shoulder height. Because this reaching backward and shoulder, there will require the rotation as well as the elevation of the shoulder. Apprehension when sleeping with the arm overhead in abduction and external rotation, so the patient will feel some sort of apprehension. Neurological symptoms may be present, which include the tingling or burning in the lower arm and hand or localized numbness overlying the deltoid muscle. Tenderness may be present of the anterior glenohumeral joint line and the posterior rotator cuff muscle. Now, what will be the symptoms of the posterior instability? The posterior instability as compared to anterior instability, they are very rare, and almost 2 to 3% of all the instability, they are posterior instability. Possible subacromial or internal impingement may be present. In posterior instability GERD, which means the glenohumeral internal rotation deficit, they may be present. Pain and clicking will be present just like the anterior shoulder instability. And just like the anterior shoulder instability, they will be increased joint accessory motion, particularly in the posterior direction. If there is anterior instability, so there will be more translation in the anterior direction. If there is posterior instability, there will be more translation in the posterior direction. History and physical examination. Uh, when we, as a therapist, when we are going to examine a patient with shoulder dislocation, we need a very comprehensive history. For that, we have to examine all the neighboring areas, including the cervical area, including the elbow joint, just because to have that data from all the surroundings, to have a clear picture of the patient. So clinicians should obtain a comprehensive history, and they should document any detailed elements regarding the index injury for both first time versus chronic presentation dislocators. अच्छा, यहाँ पे एक पॉइंट है इंडेक्स इंजरी. व्हाट डज इंडेक्स इंजरी मीन? एक बंदा है, उनको 2 साल पहले जो है इंजरी हुई थी या डिसलोकेशन हुई थी, और ये डिसलोकेशन जो है उनको बार बार होती रही है, और इन 2 साल में तकरीबन उनको 20 दफा जो है ये डिसलोकेशन हो चुकी है. अब जब उसको 2 साल पहले पहली दफा जो उनको डिसलोकेशन हुई थी, दैट इनिशियल the most initial episode of dislocation, that is known as the index injury. और फिर इसके बाद जितनी भी डिस्लोकेशन आती है उसको फिर कहते हैं रिकरेंट डिस्लोकेशन या रिकरेंट इंजरी. सो इट मीन डिस्लोकेशन दैट मे बी इंडेक्स इंजरी, और इफ देयर इज रिकरेंट. अगर रिकरेंट डिस्लोकेशन किसी में नहीं है, एक बार उनकी डिस्लोकेशन हो चुकी है और अब उसकी ट्रीटमेंट ले रहे हैं, तो फिर इंडेक्स इंजरी की जरूरत नहीं है. द रीजन इज दैट इंडेक्स इंजरी इज used when there is some recurrent dislocation, और फिर इसके symptoms देखे जाते हैं कि ये what was the intensity of the symptom in the when it was the index injury, and now what changes have been there and when there is a recurrent dislocation. Elements often include in that comprehensive examination of that patient with the shoulder instability. They include the first-time dislocators. So, patient presenting after a single acute event typically report a recent history of high-energy trauma or collision impact causing a dislocation. So, if it is the index injury or the first time that there is dislocation, so mostly it will be traumatic. It will be high energy collision with the sports other opponent player or with the colleague or with the teammate. Similarly, clinician should also inquire regarding the degree of trauma, that it was the high energy trauma, it was the low energy trauma, what was the mechanism of that injury, what happened actually when there was dislocation of the shoulder. So what was the sports, in which sports it just occurred over sports activity and position. Discern a true dislocation from a subluxation event, and then this can be just checked through the radiographs, which we will discuss in the next lecture. Elicit the requirement for unfeared or unsight manual reduction and presentation to the emergency department plus sedation requirement. इसके बारे में जो है क्लियर कट जो है डिसीजन लेना चाहिए. क्रोनिक केस में वहां पे पेशेंट जो टिपिकली आ जाते हैं उनमें थोड़ा सा रेंज ऑफ मोशन जो है लिमिटेशन होती है, और ये इसलिए होती है कि बिकॉज ऑफ द पेन ही जस्ट हैव रेस्ट्रिक्टेड द शोल्डर जॉइंट इन डिफरेंट डायरेक्शन, और इसकी वजह से उनकी जो रेंज ऑफ मोशन है ये लिमिटेड हो जाती है, और ये इतनी लिमिटेड हो जाती हैं कि इनकी जो डेली लाइफ की एक्टिविटीज होती हैं ये उसको भी मुतासिर करते हैं, और द पेशेंट जो है नॉर्मल एक्टिविटीज जो है वो भी नहीं कर सकता बिकॉज ऑफ दैट लिमिटेड एंड restricted range of motion. So clinicians should gather a detailed history for any inciting instability events. The initial injury may be overlooked and the patient subsequently develops chronic instability recurrence. Most of the cases when there is shoulder dislocation, the patient is just overlooked. Overlooked mean when there is lacking of the diagnosis of the actual condition, and instead of that actual diagnosis, there is diagnosis of something else which is actually not present in that situation. Heightened clinical suspicion is warranted in the setting of history of seizures and electrical shocks, and if there is polytrauma in which the shoulder instability was overlooked or missed. तो फिर इन सिचुएशन में थोड़ी सी जो है और भी डिटेल से और गौर से जो है ये हिस्ट्री लेनी चाहिए. अब अगर लो एनर्जी रिकरेंट सबलक्सेशन केसेस है तो शोल्डर इंस्टेबिलिटी जो है इसके एपिसोड ड्यूरिंग द स्लीप भी हो सकते हैं, और ये अगर ड्यूरिंग द स्लीप देयर इज शोल्डर इंस्टेबिलिटी एपिसोड तो इसका मतलब ये है कि जो इंस्टेबिलिटी है दैट इज मच मोर कॉम्प्लेक्स, और इसमें जो है बोन लॉस जो है ये इन्वॉल्व होती है, क्योंकि ड्यूरिंग द स्लीप वहां पे देयर इज मूवमेंट एट द शोल्डर जॉइंट जिसके, और यहाँ पे तो ऑब्वियसली बोन लॉस हो चुकी है, सो मामूली सी जो भी ट्रांसलेशन हो जाती है सो देयर विल बी डिसलोकेशन. सो इफ देयर इज that shoulder instability episodes they occur during the sleep, so it indicate that there is a high intensity of a high chances of the that bone loss on the both sides. Clinicians should elicit for any medical comorbidities or family history of underlying connective tissue disorders or generalized hyperlaxity on the examination. Now, as we discussed earlier, there are different regions that should be examined. They should be assessed in that comprehensive physical examination. The examination should be started from the neck and then the shoulder and then towards the elbow region. The coexisting cervical radiculopathy should be ruled out in any situation where the neck or the shoulder pathology is consideration. and specific tests they are present which can help the clinician to rule out the cervical radiculopathy. And these special tests, including the Sperling maneuver, reflex testing, and a comprehensive neurovascular examination. Observation of the neck and posturing, muscular symmetry, as well as palpable tenderness, and active passive range of motion should undergo evaluation, and they should be good for the both sides. In the shoulder exams, examiners should observe and compare bilateral shoulder girdle for any notable asymmetry. This asymmetry should be checked at both sides. It should be checked on the head, the top of the shoulder. It should be checked at the inferior angle, that what is the distance between the spine lateral border of the spine, or the distance between the spinous process and the inferior angle of the scapula. If the distance between the mid of the spine and the inferior angle is dissimilar on the both sides, one side it is larger and the other one it is shorter, so it will again call as the inferior asymmetry. And if one shoulder is there is hiking up one shoulder and there is dropping of the other shoulder, so that will be the superior shoulder asymmetry. Similarly, the scapular posture should be observed, that if there is winging of scapula or not, there is rotation, upward rotation of the scapula, if there is interior tilting. So all these should be checked during the observation of the scapular posturing. Muscle bulk should be checked on the both sides for both the hypertrophy, as well as that should be checked for the atropic changes. Specifically, the atropic changes should be checked in the supraspinatus muscle and the deltoid muscles. Because these two muscles, they are very common for that muscle wasting. इनमें एक वजह तो ये हो सकती है कि यहाँ के जो एक्सियल नर्व होती है उसकी इंजरी हो सकती है, जिसकी जो एक्चुअली सप्लाई करती है डेल्टाइड को। तो अगर एक्सियल नर्व जो है डैमेज हो जाती है तो वहाँ पे उसकी नर्व सप्लाई मुतासर होगी, जिसकी वजह से उसकी वेस्टिंग है या एट्रोफी जो है ये शुरू हो जाती है। और आगे हम ये शो करेंगे कि नॉर्मल पीपल में अगर हम उसको देखें, लेटरली डेल्टाइड को देखें, तो ये गोल सा एक बल्क होता है डेल्टाइड मसल का, लेकिन उस साइड पे जहाँ पे शोल्डर डिस्लोकेशन हो गई है और ये क्रोनिक केसेस, मोस्टली द पर्सन विल बी प्रेजेंट विद फ्लैट डेल्टाइड, उसकी बल्क जो है उसमें काफी रिडक्शन जो है आ जाती है। Similarly, the skin should be observed for the presence of any previous surgical incisions, laceration, scars, erythema, or induration. Induration से मुराद है the hardening and thickening of the skin, and erythema से मुराद है redness of the skin. Laceration means that's cut in the skin. Scars, that is the remains points and remaining just indication of the previous healing of the previous injury. Chronic instability patient will almost always exhibit at least a mild degree of asymmetry. The deltoid muscle often demonstrate atrophy in the chronic dislocators. The findings can be rather subtle, specifically in the obese people. In the setting of chronic interior instability, the clinician may be able to appreciate a palpable interior fullness. Now, what does interior fullness mean? We will discuss in the upcoming slides. Upon observation, the posterior shoulder, when viewed from the side of the patient, will be relatively flat relative to the interior fullness. Similarly, the chronic interior and posterior instability patient may also exhibit corresponding posterior and interior acromial prominences respectively. Scapulothoracic motion and scapular winging should also be evaluated during the active and passive motion. So these are the clinical presentation of the chronic case. We can see here, this is actually that interior fullness of the shoulder. If we see this on the right side, there is a bulk muscle on the deltoid, but here it is just very flattened deltoid. Similarly, there will be prominence of the acromion, and the arm will be in slight abduction, as well as in somehow a little bit external rotation. After the observational, the active and passive range of motion should be assessed and should be documented. This exam finding may be limited in the setting of initial fall-off in the clinic after an acute instability event, just because there may be swelling, there may be too much painful situation, and in that case, then it is very difficult to check that range of motion, and the patient that will be restricted in multiple directions just because of that pain and swelling. And specifically, if there is granite bone loss, then there will be the situation where it will be very difficult to have that assessment of all these findings. The range of motion will be very restricted and limited in specifically when the granite bone loss is present. In the setting of the chronic interior instability, the clinician should attempt to assess the current status of the axillary nerve. That is very important. Axillary nerve is the common consequence of that interior instability. If this nerve is injured, there will be disturbance in the nerve supply to the deltoid muscle. That's why how we can check the status of the axillary nerve. If we check the function of the deltoid muscle, if the function is excellent, it means that there is nothing wrong to the that axillary nerve that is undamaged. Similarly, we will check the strength of the rotator cuff muscle, specifically that the internal and external rotators. Specific testing of the supraspinatus muscle can be difficult when the passive range of motion is limited. So when there is the patient can do some of that abduction, then we can check the supraspinatus. Otherwise, if the passive range of motion is limited, then it is very difficult to test the strength of the supraspinatus. If there is any evidence of the weakness in the muscle, specifically the rotator cuff muscle or the surrounding, so it indicating that some neurological deficit may be present, just like we discussed for that axillary nerve, and that when the axillary nerve is injured, when there is some damage to this nerve, so obviously there will be weakness of the deltoid muscle, as well as if there is injury to some other structures, including that are nerves which are just exiting that shoulder and they're coming towards down to the arm. So there may be tingling, there may be some neurological sensation, there may be pain and needles in the hand in the distribution of that nerve which has been damaged. Similarly, the clinician should perform a detailed sensory examination in all acute and chronic instability patients. In addition to axillary nerve function, motor function of the elbow, wrist, and hand should undergo an assessment to rule out the possibility of a brachial plexus injury associated with the dislocation. Specifically, if there is tingling and pain in needles in the fingers, that will indicate that some brachial injury has been associated with that interior dislocation. In the same way, the distal pulses should also be assessed at the wrist as well. Older patient and in the setting of suspected concomitant shoulder pathological conditions like the rotator cuff injuries or the bicep tendon pathology, specialized testing for these pathology should also be in consideration. Now, different tests that can be used just to check and just to provoke that condition, that if just to assess that either the anterior instability is present or not. First of all, we will talk about the anterior apprehension test. In this interior apprehension test, the patient will be lying on the couch in the supine position on the examination table, while the examiner positions will be just at the side of the patient. The examiner then will position the shoulder to 90 degrees of abduction and 90 degrees of external rotation while applying an interiorly directed force to the proximal humerus. तो यहाँ पर अगर हम देखें, सबसे पहले तो यहाँ पे पोजीशन क्या होगी, 90 डिग्री ऑफ द शोल्डर एबडक्शन और फिर इसके बाद 90 डिग्री ऑफ एक्सटर्नल रोटेशन. अब इसी दिस इज दैट situation, this is that position in which there is high chances of the interior dislocation, because in this 90-degree abduction there is responsibility of providing the stability to this 90-degree abducted arm is just on the that inferior glenohumeral ligament complex, and the restraint, the statics restraint, the middle glenohumeral ligament and the superior glenohumeral ligament, they will be inactive, they will be in loose position and during that 90-degree of abduction or elevation. So during this 90-degree of external rotation and 90-degree abduction, then the therapist will apply some interior directed force to the proximal humerus. Now, when the test will be positive, if this maneuver it produces the symptom of the interior instability, which is actually the pain and apprehension, then this test will be considered as positive. Apprehension at lower degrees of abduction may suggest a glenoid bone loss. Usually, apprehension will be present at the 90 degree or above 90 degree abduction with external rotation. But if the apprehension is still present at less than 90 degree of abduction and specifically without that external rotation, so that will indicate that there may be some glenoid bone loss. So the hand should be like here, like in this picture, there should be in the proximal picture and the proximal that humerus. This picture is just added just for that position of the patient. There should be 90 degree of abduction and 90 degree of the external rotation. The second test is the job relocation test. The job relocation test is utilized with the previous apprehensive testing maneuver. Once the patient reports a subjective feeling of the reproduction of the shoulder instability symptom, the examiner applies a posteriorly directed force. और अगर इस posterior directed force से उसका जो apprehension position था उस similar अभी भी रहता है, so then this test will be considered as positive. Resolution or improvement of symptoms indicate in the positive test result. So that is that job relocation test. Load and shift test. Here there are two concepts. One is the load and the shift. This load means the axial load through the elbow to the center of the humeral head within the glenoid fossa, and then an anterior and posterior directed force is then applied at different position, including neutral 0 degree of abduction, 45 degree of abduction, and the 90 degree of abduction. So this is that axial loading from the elbow, so that will be in that direction towards the glenoid fossa. And when that axial load is provided in the direction of the glenoid fossa, then there will be translation of that interior and posterior. And that posterior and posterior directive force is then applied not only at 0 degree, but also at 45 degree as well as in the 90 degree of abduction. Increased translation at increasing degree of shoulder abduction that implies the compromise of the IGHL, that the load and shift test is up to 98% specific. But the problem with this test is that sensitivity is too poor, and it will be and the therapist will be unable to detect that either it is a unidirectional instability or it is a multi-directional instability with the job relocation test. A combination of laxity and a reproduction of the symptom determines a positive or negative result. Now, if on the basis of that shifting, the interior instability can be graded as grade 1, grade 2, or the grade 3. Grade 1 is when there is shifting between 25% and 50%. And the grade 2 and the grade 3, both they will be 50% or more than 50% shift. But in the grade 2, there will be spontaneous reduction when the force is stopped. But in the grade 3, if the force is stopped, there will be more than 50% shift without spontaneous reduction, and the dislocation will remain. So that will be the grade 3. While in the grade 2, when the force is removed, there will be spontaneous reduction. Other exams consideration, the shoulder also should be examined for the associated posterior instability as well as in the multi-direction instability. If the patient is with the MDI, so in the interior dislocation के साथ साथ उनको posterior instability भी हो सकती है. During surgery, examination under anesthesia should occur and the results compared with those of the uninjured contralateral side. Depending on the patient age, the clinician may expect various degree of associated shoulder pathologies. मिसाल के तौर पर जो ओल्डर पेशेंट होते हैं उसमें अगर एक्यूट शोल्डर इंस्टेबिलिटी होती है तो उनमें सिर्फ और सिर्फ डिस्लोकेशन नहीं होती बल्कि उसमें यूजुअली रोटेटर कफ इंजरीज भी हो सकती हैं और उसमें चूंकि टेंडन और ये लिगामेंट्स थोड़े से ब्रिटल हो जाते हैं with the passage of time. So that's why in such patient, older patient geriatric population, when there is acute shoulder instability, so there is also high chances of the tear of the rotator cuff tendon, specifically the supraspinatus tendon, that is very common in the if there is dislocation in the geriatric population. Pain with weakness against resisted abduction or external rotation, they will suggest that the presence of associated rotator cuff injuries. For example, patient with interior shoulder instability in end-range position that demonstrates some degree of external rotation weakness. And what are the external rotator? Both the internal and external rotator, they are the rotator cuff muscles. An increased level of passive external rotation with the arm at the side suggests a subscapularis tendon tear, whereas the reduced external rotation in the 90-degree of abduction may indicate a medially healed being cartilage. So these points, they are very important to remember that when that may be a case when there is external rotation limited, and that limitation in the external rotation is just present when the patient brings the arm into 90 degree of abduction. So what does it indicate? It indicates that there is medially healed being cartilage. So that was the end of today's session. We discuss in this lecture about the multi-directional instability. And after that multi-directional instability, we discuss what does it mean and how it can be assessed. Then we discussed what is the difference between the joint laxity and that instability. We discussed some causes of that hyperlaxity when it is present congenitally. We discussed the Bruton scale as well, the total score of it, and what are the components of the Bruton scale, minimum and maximum score of this scale, and according to different researchers, what is the association of this Bruton scale with the uh, episodes of the recurrent dislocation of the shoulder dislocation. We then discussed the long-term implication, in which we discussed the alteration in the biomechanics of the shoulder girdle. We discussed the recurrent instability, dislocation arthropathy. After that, we discussed the histopathology, that what are the different changes in the tissues occur after the shoulder dislocation. At the end, then we discussed the clinical presentation of a patient with some instability. So if the patient is with interior instability, it will be present with the dead arm syndrome, rotator cuff weakness, increased joint accessory motion, wing cartilage, Hegel, Gagel, or other associated glenohumeral ligament injuries. Hill-Sachs defect, Hill-Sachs lesion. We have discussed this Hegel and Gagel in detail when we were discussing the unidirectional shoulder instability. We also discussed that reverse Hegel, and we also discussed that Boni Hegel or Boni Gagel. Discussed the symptom of the recurrent interior instability. And then we discussed the symptom or clinical presentation of the posterior instability. After the clinical presentation, we started the physical examination and history. So हमने उसमें कहा कि there should be a very comprehensive clinical examination जो neck and cervical spine से शुरू होगी, shoulder exam पे, और उसके बाद जो है elbow पे जो है ये खत्म होनी चाहिए. हमने इस पे डिस्कशन की कि when the patient is with the interior dislocation and if there is a recurrent dislocation, so ये वाले symptoms जो है उसकी inspection में हमें मिल सकते हैं कि cranium will be prominent, there will be anterior fullness just below the coracoid process. ये जरूरी याद रखिए कि इंटीरियर फुलनेस जो है ये मोस्टली जो कोराकोइड प्रोसेस की नीचे होती है. deltoid may be present with atrophy. So atrophy mean कि the bulk जो है थोड़ा सा कम होगा और ये बिल्कुल straight इस तरफ flatten होगा, which mean there will be atrophy of the deltoid. And this deltoid atrophy is because of the injury to the axillary nerve, which is the motor supply of this deltoid muscle. The arm will be slight abduction and as well as in some internal rotation. ऐसे पेशेंट जिनमें इंटीरियर इंस्टेबिलिटी होती है, यूजुअली जो साइड मतलब ठीक होता है, साउंड होता है, ये उसको सपोर्ट कर रहा होगा. Dislocated shoulder arm will be in slight abduction and थोड़ा सा internal rotation towards that होगा और ये उसको सपोर्ट कर रहा होगा. जो ठीक साइड है ये dislocated साइड को सपोर्ट कर रहा होगा. So that was all about the examination and special tests used for the assessing and diagnosing of the interior instability. So thank you so much to all of you. Have a nice day.